any problem with spironolactone. And so the indication for spironolactone may be initial therapy. I don't need the really effective furosemide yet. I don't need that much diuresis. So I'm early in the stages of congestive heart failure. Aldosterone is going up. Well, let's start with spironolactone because it's easier to titrate and easier to use. The one thing I will tell you, and I don't have a slide here, is this is not approved for use in dogs. A lot of its efficacy is because of an active metabolite. But what I want you to hear is there's variable disposition. And so you may have to adjust the dose pretty aggressively to get this drug to work. And liver disease would be one of the indications, because remember I said liver disease, and we're talking about chronic liver disease, liver failure. That is a high aldosterone state, so this would be another indication. Now, one more point. Why do I have cardioprotection down here? What's that all about? Do you remember?
You need the potassium for contraction?
Well, yes and no. The main thing is, remember when we were talking about all of these bad gujus, all these bad mediators coming out? Remember we said they all contribute to the myocardial remodeling that is killing the patient. That is why a patient with congestive heart failure is going to die. But eventually, no matter what you do, because of that myocardial remodeling. So if we can slow that myocardial remodeling down, then we can slow the progression. Aldosterone is one of those mediators. So if we block the effects of aldosterone, then we're helping block the effects of those mediators that cause remodeling. And so spironolactone, more than other diuretics, may be useful for cardioprotection. And that might be a reason to bring it on board earlier rather than later. Is that making sense? Okay, so that's what that is all about. Okay, so that finishes our discussion of drugs that alter urine formation. As I noted before, there are drugs which alter urinary pH. The most common ones we use are urinary acidifiers because in an alkaline urine pH, those struvite crystals tend to be formed, and we don't like that. And so we're frequently trying to acidify the urine. And so D-L-methionine and ammonium chloride are the most common ones that you see. You're much better off trying to do this with dietary management because these will not work long. There are some alkalinizers, and there are some drugs that we use for specific stones, like citrate, potassium citrate, for oxalate stones, but those are not that commonly used. I'm not going to talk about them in this class, but they are a group of drugs that you'll probably talk about when you get to your urinary classes and you talk about stone formation. Okay, any questions about diuretics or drugs that alter urine formation? Okay, let's go ahead and get started on our vasodilators, and maybe if we get far enough, we won't have to worry about it breaking into your break time. All right. So vasodilators 1. You have those and you're okay? You're ready to go? Okay. So what we're doing now is we're shifting to, remember the general order of drugs that we were going to talk about are the general order of use in a patient with progressive congestive heart failure. So we talked about preventing sodium retention as much as possible. Well, that's great for preload, but that's probably not going to help us with afterload. So now we're going to transition and talk about those drugs that we might use to directly target afterload. And then toward the end, we're going to talk about drugs that can target preload and afterload in the emergency patient. So we're going to talk about vasoactive drugs. So I don't talk about just arterial dilators. That will be the predominant group. But we will also have to mention venodilators as well. Okay. When we finish that, and if we have time today, I might just briefly introduce you into antiarrhythmics, and if I don't, you would be much better off if you would read ahead at least the first session, because antiarrhythmics are hard to understand. We're going to try and make it easy, but the more reading ahead and thinking you can do, especially about the action potential, the better off we're going to be. And then finally we'll finish up with positive inotropes. Okay. So vasodilator therapy is not that hard to understand. There are going to be a couple of kooky things that we have to understand, like ACE inhibitors. But the reality is, if you understand what veins and arteries do, then you can understand how to use these drugs. So, if you're going to target the vasculature, the most common side that we're going to target is the arterial side. We're going to want to reduce afterload. Now in the dog is hypotensive. The afterload makes them normal tensive. So all we're doing here is we're not changing blood pressure. We're decreasing the workload against which the heart has to work. In the cat does suffer from hypertension. So in the cat, we're likely using these drugs to bring them back down to normal blood pressure, but we're still decreasing afterload. Is that making sense? In both cases, there's increased afterload. Okay, in both cases, we are going to decrease the work against which the heart has, well, we're going to decrease the heart's work, and that means, therefore, we're going to decrease myocardial oxygen demand. So in both cases, we're going to make the heart happier. So that's a good thing. But we are going to refer to this as decreasing resistance. That makes sense. You know that arterial vessels are resistance vessels, right? Venous vessels are capacitance. If we dilate arteries, we decrease resistance, we decrease pressure. If we dilate veins, we increase capacitance, we decrease preload. All right. So, if we look at the other side of this, if we increase the capacitance of the veins, we're going to decrease preload. Has nothing to do with systemic blood pressure. Did you hear that? Decreasing preload has nothing to do with decreasing systemic blood pressure. The only way we can manipulate systemic blood pressure is on the other side of the heart, by decreasing afterload. So if we decrease preload, we're going to decrease the filling of the heart. And we simply do it generally by increasing the capacitance of the veins. We simply are moving the blood away from the heart into the veins. That's all we're doing here. We will still decrease myocardial oxygen demand when we do that, but in this scenario, we're only buying time, because most of these drugs that decrease preload, ultimately, unless we get rid of that extra volume, it's not going to do us much good. Okay, so let's talk about the arterial side first. So this is a smooth muscle of, or a diagram of the smooth muscle of the vasculature. And notice if you look here, we've got beta receptors that cause relaxation because they cause cyclic AMP to be taken up, well, they cause calcium to be taken up into the sarcoplasmic reticulum. Over here, we've got cyclic GMP that also causes relaxation because it causes or it inhibits myosin-actin interactions here. So what we're going to talk about are the different drugs that we use. Overall, we can also prevent contraction by simply decreasing calcium from going into the cell. And that's going to be our major form of causing vascular relaxation. So one of the points to remember is in the heart, when we increase cyclic AMP, we cause contraction. But in the vasculature, when we increase cyclic AMP, we cause relaxation. All right, so that's the point of this slide. So these are the drugs that are used in animals to decrease afterload. These are primarily arterial in action. Hydralazine, I have it in parentheses because we're not going to talk about it much. It is a drug that is used for non-responders, so it does show up in the literature. I want it to be in your notes so that you can refer to it, but we are not going to use it as a model drug. It probably works by increasing cyclic GMP and probably causes relaxation that way. The main drug that we're going to talk about, the first model drug, is amlodipine. It is a calcium channel blocker. It's going to target calcium influx, therefore it's going to decrease resistance in those precapillary arterioles. Primary use is going to be cats with hypertension. Of course, the biggest class of drugs that we're going to talk about are going to be the ACE inhibitors. And the ACE inhibitors don't work here The ACE inhibitors actually work further up by inhibiting angiotensin's effects. And then we are going to talk about sildenafil, Viagra-like drugs, and we're going to actually talk about them in the pulmonary vasculature. These other three classes of drugs are in the systemic vasculature. But we do have to deal with pulmonary hypertension, and now, nicely, now, we actually have a drug that we can use. Before we did not. And then the last drug that I've got here that actually dilates is acepromazine. I've got it in parentheses. We've already met this drug. Where do we meet acepromazine? So it's a behavior modifying drug, not a particularly good one. We also use it as a sedative. But remember, one of the side effects of this drug was hypotension because of alpha blockade. So we'll put that in parentheses. Now, we will also talk about arterial vasoconstrictors at the end. What is an arterial vasoconstrictor? A drug that actually increases afterload that we've already talked about. Think of Dr. Judd. Do you remember? What causes vasoconstriction? In fact, when we go back to Chesty, what is one of the signals that causes vasoconstriction? Alpha stimulation. What drug does that? Epinephrine, that's right. So epinephrine will be discussed not as a dilator, but as a constrictor. Okay, we'll do that at the very end. All right. One last thing, and that's prazosin. I did put this in here. Does anybody know where prazosin is used most commonly? Yes, a block tom. We use prazosin because of the alpha blockade effects in the urinary bladder sphincter. It actually is an arterial blocker that shows up intermittently, and it is not a model drug, but again, my goal is to have you have the pieces of information. This is a drug that you will see potentially used when you can't pass a catheter or to help pass a catheter in a blocked tom, not because of the vasculature, but because of the urinary sphincter. It will target the vasculature as well, but that's not what you're using it for. Okay, so right off the bat, what's going to happen if we're overzealous with our drugs that cause arterial vasodilation? We're going to have a decrease in blood pressure. What's going to happen? What's the kidney do whenever there's a decrease in blood pressure? It puts into play the renin-angiotensin-aldosterone system. So just like our diuretics, if we are overzealous with our arterial dilators, we are going to do the very thing that we're trying to prevent, and that is a response to vasoconstriction. So of all of these drugs, a shared pharmacodynamic effect is going to be decreased afterload, targeting the precapillary arterioles, and because of that, if we are overzealous, we're going to see hypotension, reflex renin release, reflex tachycardia, and reflex increase in afterload. And therefore, once again, we're going to titrate these drugs to animal response. And how are you going to monitor these animals? We talked about monitoring a diuretic. How are you going to monitor these animals? How? Blood pressure? Blood pressure, that's right. So if you are not prepared to monitor blood pressure, if you do not do it well, this is not a class of drugs that you should be using by yourself. You should be sending these patients to somebody that is capable of doing that. So get yourself a good blood pressure monitor and get yourself trained well to do it and use that to monitor your patients, because by the time you see the tachycardia, by the time you see the tachymucous membranes and the poor capillary refill time, you've already put into play the very things that you don't want to happen. Okay, so let's start with the easiest drug, and that's the calcium channel blockers. Now, there are 5 different kinds of calcium channel blockers in the body. We just want to target the L channels. Those are the ones that are in the periphery that we want to target. And the way that I keep them straight is L-amlodipine. Later, we're going to talk about calcium channels in the heart, and we're going to use diltiazem to target those, and those are T channels. So diltiazem has a T in it. So that's how I keep these things straight. Amlodipine, L, vasculature. Diltiazem, T, heart. So the nice thing about amlodipine, and the L stands for long-acting as opposed to the T, transient, tiny. I wouldn't pay attention to that. I just learned L for amlodipine. The nice thing about this is we're going to have minimal effect in the heart when we use the L channel blocker. And so amlodipine is going to be a arterial dilating drug. It is going to target primarily the arteries. Very little, if any, venous effect. And I'm not going to ask you that. I would expect you to answer, this is an arterial driving drug, an afterload drug, not a preload drug. So, there's not much to say about its disposition because we don't know. This drug really has not been studied well in animals. What we do know is that in most species, it is both liver and kidney. I'm not sure that makes a world of difference to you using it because how are you going to use this drug? What are you going to do to monitor the patient? Blood pressure. So it really doesn't make any difference right now if it goes out via the kidney or the liver. Yeah, if you have renal disease, you're just going to monitor these patients a little bit more closely. What we do know in dogs is that the half-life is about 30 hours. Okay. So how long before you get to steady state with this drug? 90, that's right. So 3 to 5 days, maybe a week. Okay, so, and it's probably a little bit longer in cats. We don't know that. We're just assuming it's a little bit longer in cats. So this is not a drug that's going to happen overnight, right? What we may want to do is load this drug if we have to get a rapid response, right? The other thing that that causes a delayed response is, and we're going to see this with the ACE inhibitors as well, it takes a while for the body to respond to the maximum effect of these drugs. And we saw this with behavior modifying drugs as well. So amlodipine doesn't work fast. You're going to have at least about a week to steady state, and then you're going to have a little bit more time until the body finally adjusts to the maximum effect. So bear that in mind. Be patient. As you're titrating to the animal's response, be patient so you don't get them in trouble. So drug interactions, really not much to worry about. Diltiazem, we're going to see drug interactions, but not with amlodipine. Side effects, we've already talked about it. So indications, the primary indication, the most common indication is going to be cats with primary hypertension. And then if there are secondary causes of hypertension, then this drug is also going to be the drug that you'll use. And in cats, renal disease, hyperthyroidism, maybe hypertrophic cardiomyopathy, or some situations where you can see increase in blood pressure. Now dogs, the primary indication in dogs is they haven't responded to your ACE inhibitors, which is our next class of drugs. All right, any questions about amlodipine? Okay. So it looks like we have about 7 minutes before break, is that right? Mm-hmm. Okay, let's get started on the next set because then what I can do potentially is spend just a little bit of time with you on antiarrhythmic drugs because they're going to be a little bit difficult to work with. All right, so let's talk about the angiotensin converting enzyme inhibitors. We've been talking about them intermittently. Here they are. So what they do, of course, is they inhibit the conversion of renin to angiotensin 1, I'm sorry, from angiotensin 1 to angiotensin 2 that happens in the vasculature. So what we're doing is we're preventing the formation of angiotensin 2. Now the nice thing is when that happens, we'll see here in just a couple minutes, we get rid of a whole bunch of side effects. One of the things I want to warn you about is, this is true systemically, but each tissue actually has also its own little angiotensin let me just say production of angiotensin. So while I've got this drawn that it happens systemically, this also happens at the tissue level. And the only reason I bring this up is we're going to have to talk about therapeutic failure. And that's going to play a role in therapeutic failure. All right, so I've listed the drugs, the most common drugs. Captopril is the oldest drug. We don't use it anymore. Enalapril is the drug that I've chosen as the model drug because that drug was approved for use in animals in the United States. Now, we don't use that drug anymore. What do we use instead of the Enacard that was approved for use in dogs? Does anybody know? We use the generic human form because it was much cheaper. And so this drug was simply withdrawn from the market, not because it was a bad drug, it's just veterinarians didn't use it. They went to the human market and used the human drug. It's a good example of the frustration of pharmaceutical companies. They go through the trouble of approving a drug in veterinary medicine. We turn around and use a generic human drug and they don't recover their costs. And this drug costs them a lot of money. Benazepril. How many of you are familiar with benazepril? Okay, that's also available in the United States, human, and it's approved for use in Europe in animals. And the biggest difference between the two is probably frequency of administration, once a day versus twice a day. But the other biggest difference is benazepril is approved for use to treat renal disease, and we'll see that as we come forward. And then lisinopril, if you just want to make a mark, why would we use lisinopril? I'll mention it again because it doesn't require activation. So we'll mention that when we get there. All right, so here's our pathway. Here's our angiotensin II, a reminder that it causes increased afterload, a reminder that it increases aldosterone and therefore causes preload increase as well. And because angiotensin II does all of these things, and it does all the afterload things and all the preload things, it is a major role player in the myocardial remodeling that is responsible for progressive renal disease. So in one fell swoop, we're going to get rid of all of this stuff. And that is going to be a good thing. And then on top of that, it turns out that these drugs actually have a little bit of a positive inotropic effect. So we're going to so the major effect is decreasing afterload. That's the primary thing that we're after. But we will decrease preload, and we will actually cause a positive inotropic effect. And then we're going to decrease myocardial remodeling. So it's a pretty nifty little